Welcome back to the Deep Dive. Today we're doing something a little different.
Yeah.
We're stepping into the world of medicine, specifically the fascinating process of unraveling a complex clinical puzzle, much like the clinical pathological conferences you might read about in top medical journals.
Ah, the CPCs. Love those. Real medical detective work.
Exactly. Our mission today is to take you through a real medical case, step by step, using only the information as it would have unfolded for the doctors working on it. We've got the source material, the case notes, the lab results, the imaging reports, and we're going to analyze the findings together, thinking through the possibilities at each stage.
That's right. Think of this as putting on your medical detective hat alongside us. We'll start with the patient's initial symptoms, then progressively reveal more details. Findings from their physical exam, lab tests, imaging studies. Our goal is to explore the differential diagnosis at each turn, that list of possible conditions that could explain the findings and see how the picture changes with new information.
And just like in a real CPC, we're going to hold off on revealing the final diagnosis until the very end.
Yeah.
So get ready to analyze the clues, weigh the possibilities, and see if you can solve the puzzle with us.
Okay, let's dive in. What was the initial presentation? What were the first signs that brought this patient to medical attention?
Okay, we begin with a 53-year-old woman. She came to the hospital because of symptoms that had been getting progressively worse. The main issues were persistent headache, difficulty keeping her balance and walking steadily, what clinicians call gait instability, and significant weight loss.
Right off the bat, those symptoms, especially their progressive nature, that immediately raises concern. Individually, headache is incredibly common. It could be anything from tension to something more serious. Gait instability, that screams neurological problem, likely affecting areas in the brain for balance and coordination. And unexplained progressive weight loss, that's a major red flag for an underlying systemic illness.
Yeah.
Something affecting the whole body, like maybe chronic infection or malignancy.
So putting them together.
Exactly. When you combine progressive headache, gait problems, and weight loss in one patient, you start thinking about serious conditions, maybe affecting the brain directly, or maybe widespread and impacting the brain secondarily.
Okay. Now, about 2 months before she arrived at the hospital where this detailed evaluation took place, she'd had an episode of vertigo, that dizzy, spinning sensation that actually went away on its own.
That's interesting history. Vertigo can come from the inner ear, sure, but it can also be a symptom of issues in the brainstem or cerebellum, those same areas important for balance.
Right.
The fact that it resolved might have initially seemed, well, reassuring, maybe just a benign inner ear thing.
But it came back.
Well, the current symptoms returned and worsened over 2 months. That tells you this wasn't just a fleeting problem. Whatever caused that initial vertigo, it seems to be part of this larger progressive process.
Makes sense. Because her symptoms continued to worsen, she actually sought care at a different hospital one day before arriving at the hospital where our source material originates. So let's look at what they found during that first hospital visit.
Okay, the vitals. Blood pressure was 107.0145 millimeter Hg.
Wow, that's high.
That's significantly elevated, yeah. Stage 2 hypertension, even severe hypertension range. Her temperature, pulse, respiratory rate, oxygen saturation, all within normal limits.
So no fever at that initial visit, which might, lean slightly away from an acute infection, but certainly doesn't rule it out. But that blood pressure is definitely notable.
It is. Severe hypertension can sometimes cause headaches. And long-term, it's a risk factor for a vascular problem in the brain, like strokes. It's a piece of the puzzle we have to keep in mind, but it doesn't immediately explain all her neurological symptoms.
Okay. On examination at that first hospital, she was alert and oriented. That's good, suggests her consciousness and basic cognitive function were okay. But her speech was noted as slow.
Slow speech.
Neurologically, they observed bilateral endpoint horizontal nystagmus and mild dysmetria on the right side during the finger-nose-finger test.
Okay, let's break down those neuro findings. Slow speech can sometimes relate to neurological issues affecting motor control of speech, or maybe part of a more generalized psychomotor slowing. Nystagmus, that's the involuntary rapid eye movement.
Right.
Endpoint horizontal nystagmus means the eyes jerk back and forth when she looks all the way to the side. Sometimes that can be normal, but if it's prominent or uneven, it can indicate neurological dysfunction. Dysmetria, though, that's much more specific. It's a lack of coordination where you overshoot or undershoot a target, like trying to touch your nose precisely.
And it was on the right side.
Yeah, the fact that dysmetria was on the right side combined with the gait instability points very strongly towards a problem in the right side of the cerebellum or its connections to the brainstem. The cerebellum is absolutely critical for coordinating movements and balance.
Her strength and sensory function were reported as normal at this point, but she had significant difficulty keeping a stable stance, and her gait was described as narrow-based, slow, and cautious.
Yeah, see, that reinforces the cerebellar balance pathway involvement. An unsteady ataxic gait, that's the medical term for it, combined with trouble standing still, points right to dysfunction in the balance systems. A narrow-based gait can be seen in various conditions. Sometimes it's like a compensation effort. The fact that her strength and sensation were normal initially helps narrow it down, suggests the issue isn't primarily weakness or loss of feeling, but specifically coordination and balance centers.
So with these neurological signs strongly suggesting a brain problem, especially the cerebellum, imaging was the necessary next step. They did a non-contrast CT scan of her head.
Right, CT is often first. It's quick, readily available, excellent for acute bleeds, big strokes, fractures, or major mass effect, like swelling causing shifts.
But less detail without contrast.
Yeah, without contrast, it's less sensitive for subtle lesions, inflammation, many tumors compared to an MRI, but it can still show important density changes.
Okay, the CT showed an area of ill-defined hypoattenuation in the right cerebellar hemisphere. This is considered consistent with vasogenic edema. It also noted regions of white matter hypoattenuation in both cerebellar hemispheres.
Okay, hypoattenuation on CT means the area looks darker than normal brain tissue, indicating it's less dense. Could be several things. Swelling edema damage from lack of blood flow or certain lesions. Vasogenic edema specifically tells us the swelling is likely due to a disrupted blood-brain barrier, fluid leaking out of vessels into the brain, often seen with things like tumors, infections, or inflammation.
And it was in the right cerebellum.
Exactly. The ill-defined area in the right cerebellum, where her right-sided dysmetria and gait issues likely originated, that's a key finding connecting symptoms to a physical problem. The white matter hypoattenuation in both hemispheres suggests something more widespread, though maybe less severe than the right-sided focus. So based purely on this CT, they're seeing swelling, density changes in the cerebellum, consistent with her symptoms. What's on the differential now? Maybe a stroke causing edema, inflammation, a subtle tumor or infection causing swelling? Lots of possibilities still.
Based on these initial findings and the CT report, the patient was given aspirin and atorvastatin at that first hospital.
Oh, interesting. Aspirin, an antiplatelet, and atorvastatin, a statin, standard meds for stroke prevention.
Right.
Giving those suggests that stroke or a vascular event, despite the CT description leaning towards edema, was definitely high on their list at that initial hospital. Shows the uncertainty, right? Symptoms point one way, CT shows edema, but vascular risk was still strong enough to start preventative treatment.
After that initial evaluation and CT, a more detailed picture was clearly needed. So an MRI of the head was performed, both before and after, giving intravenous contrast.
Good move. MRI is way better than CT for visualizing the fine details of brain tissue. Different sequences highlight different things, and contrast. Well, contrast is invaluable for showing areas where the blood-brain barrier is leaky, which happens around many tumors, infections, inflammatory lesions.
So we expect more specific info now.
Exactly. This is where we should get a clearer picture of what that CT abnormality really is.
And the MRI did reveal a specific lesion, described as an enhancing interaxial lesion in the right inferior cerebellar hemisphere, measuring about 2 centimeters across.
Okay, critical info here. Intraaxial means it's within the brain tissue itself, coming from brain cells, not outside, like from the coverings. Enhancing with contrast means the contrast leaked in, showing abnormal or leaky blood vessels. That's a hallmark of active processes like tumors, infections, significant inflammation. And the location right inferior cerebellum aligns perfectly with her exam findings and the CT edema. We're zeroing in on the anatomical source.
This cerebellar lesion had internal signal hypotensity on T1-weighted imaging, suggesting necrosis. It also had surrounding signal hyperintensity on T2-weighted imaging, indicative of vasogenic edema.
Okay, let's break that down. MRI uses different image types, T1 and T2. On T1, fluid is usually dark. Contrast makes enhancing areas bright. So signal hypointensity on T1 inside the lesion means it looked dark. Combined with enhancement around the edge, that strongly suggests the central core of dead tissue necrosis.
Necrosis.
Yeah.
That sounds serious.
It's a very important clue. Seen in aggressive tumors, like glioblastoma, abscesses pus collections from infection, or certain granulomas, like from TB or fungal infections. On T2 scans, fluid and edema usually look bright, signal hyperintensity. So the surrounding bright signal on T2 confirms that significant swelling, the vasogenic edema we saw hints of on CT. So the MRI gives a much more specific picture, a ring-enhancing mass, necrotic core, lots of surrounding swelling, right cerebellum.
And speaking of swelling, the MRI noted local mass effect from this lesion. It was causing effacement, basically pushing on the overlying cerebellar fissures and the fourth ventricle.
Ah, the fourth ventricle. It sits right in front of the cerebellum, key part of the CSF circulation system. If a cerebellar lesion pushes on it, it can block CSF flow. That can lead to hydrocephalus fluid buildup, increased pressure inside the skull.
Explaining the headache.
Very likely. Increased intracranial pressure is a very probable cause for severe headache, and it can worsen neurological symptoms like the gait instability too. The mass effect explains a lot.
But here's where the picture gets even more complicated. The MRI also showed another enhancing lesion. This one was smaller, about 4 millimeters, and described as leptomeningeal, located along the left medial frontal lobe, with possible extension into the leptomeninges.
Whoa, okay. That second lesion is a game changer.
Why is that?
Leptomeningeal refers to the delicate membranes covering the brain and spinal cord, the pia and arachnoid mater. Enhancement there means inflammation or infiltration of these membranes. The fact there's a second enhancing lesion in a completely different part of the brain, left frontal lobe, way far from the right cerebellum, and it's in a different compartment, leptomeningeal versus interaxial brain tissue, that's hugely significant.
Suggests it's not just one isolated thing.
Exactly. We're likely not dealing with just a single localized tumor or a simple stroke. We need to consider processes that affect the brain in multiple locations in different ways, like metastatic cancer spread from elsewhere, or widespread infection like TB, fungal infections, even certain viruses, or systemic inflammatory conditions. The potential leptomeningeal extension suggests involvement along the CSF pathways, a common way for infections or cancer cells to spread within the nervous system. And this second lesion also had T2 hyperintensity, again indicating inflammation or edema around it.
So just based on imaging now, complex picture. Large, ring-enhancing necrotic lesion in the right cerebellum causing swelling and pressure, and a second, smaller enhancing lesion on the surface of the left frontal lobe, maybe spreading along the brain's membranes.
What's fascinating is that combination, interaxial and leptomeningeal lesions, really narrows the differential significantly from just a single brain lesion. We're thinking things that spread or pop up in multiple places. At this point, if you're trying to solve the puzzle with us, you should be thinking about conditions that can cause multiple brain lesions, especially ones involving both brain tissue and its coverings.
Following these complex imaging findings, she was given intravenous dexamethasone, that powerful steroid to reduce brain swelling, and meds to control her high blood pressure, amlodepine, and labetalol. She was then transferred to the specialized hospital for further evaluation, including neurosurgical consultation.
Right, managing the swelling with steroids was crucial. Try and ease symptoms, reduce risk from the mass effect. Getting blood pressure down, also important for stability. Transferring her to a specialized center, absolutely the right call given the complexity. Needed detailed neuroevaluation, maybe neurosurgery input.
Let's look at the more detailed info they gathered upon her arrival at this second hospital, starting with a more thorough review of her symptoms. Besides the headache, gait issues, vertigo history, she reported general malaise and lethargy. And it's significant unintentional weight loss of 15 kilograms. That's about 33 pounds over the past year.
15 kilos, that's huge. Substantial weight loss over a year points to a serious underlying systemic process, something consuming her body's resources.
Like what?
Unexplained weight loss is a major red flag for things like chronic infections, especially widespread ones, active cancer, or certain autoimmune diseases. Malaise and lethargy, just feeling generally unwell, low energy, that also fits with a systemic illness, not just a localized brain problem.
She also mentioned increased urinary frequency, but no other urinary symptoms like pain.
Increased urinary frequency could be lots of benign things, but in the context of potential widespread illness, it's a symptom to note. Less immediately helpful than the weight loss and neuro findings, though.
Interestingly, she denied many symptoms that might point to more common infections. No fever, chills, sinus pain, cough, shortness of breath, abdominal pain, diarrhea, nausea, or vomiting.
The absence of fever and specific organ system symptoms like respiratory or GI complaints is notable. Doesn't rule out infection or inflammation, but means she doesn't fit the classic picture of, say, pneumonia or gastroenteritis as the main issue. Could be an infection presenting atypically or affecting other parts of the body.
Let's turn now to her past medical history. Often provides crucial context. She had hypertension, we knew that, and she had a hemorrhagic stroke 13 years prior, requiring surgery, a craniotomy, to remove a blood clot. Source notes no reported neurodeficits after recovery.
A hemorrhagic stroke 13 years ago needing surgery. That significant past history tells us she has some history of cerebrovascular issues.
Does it connect to now?
Well, the fact it was 13 years ago and she reportedly recovered without deficits makes a direct connection to her current progressive symptoms, and these new lesions less likely. Doesn't explain the progression, weight loss, or the lesion characteristics. Maybe just history, or maybe points to a very long-standing underlying risk factor related in a less direct way.
Now here's the part of the history that introduces a major twist, and frankly makes things quite confusing. The patient reported that during that hospitalization for her stroke 13 years ago, she was told she had human immunodeficiency virus HIV infection and was treated with some kind of antiretroviral therapy, RT.
Whoa, okay. Here's where the case takes a truly significant turn. A diagnosis of HIV 13 years ago that immediately forces us to consider a whole new list of potential causes. Many of the conditions on the differential for multiple enhancing brain lesions, especially necrotic ones, are opportunistic infections. They happen when the immune system is severely weakened, most commonly in advanced HIV/AIDS. If she had HIV and it was progressing, that would provide a very strong explanation for maybe the oral thrush, the weight loss, and potentially those brain lesions.
But the story gets stranger. She also reported that several years later, she had further testing which revealed an error had been made, and she was told she did not have HIV infection. She then stopped taking the ART medications at least 3 years before her current symptoms started.
Okay, this is a huge question mark. Was the initial diagnosis correct? Was the subsequent error finding correct? If she was initially correctly diagnosed with HIV, treated, then incorrectly told she was negative and stopped her meds, that would mean she's been living with untreated HIV for several years, potentially leading to severe immune system damage.
Which could explain this presentation.
Perfectly. Could explain a sudden presentation now with opportunistic conditions. This piece of history is absolutely critical, needs clarification with modern testing urgently.
She reported no history of diagnosed opportunistic infections like PCP or toxoplasmosis or cancer in the past. Her recent health screenings were a negative MAN2 TB skin test 3 years ago and a normal mammogram 1 week prior.
The lack of prior opportunistic infections or cancers, even during the time she might have been off ART, if she was HIV positive, is slightly unusual for someone progressing towards AIDS but doesn't rule it out. People progress at different rates. The negative TB test 3 years ago is a relevant baseline, but if her immune system is severely compromised now, that test might not be reliable anymore.
How so?
A weakened immune system might not react to the test, causing a false negative. It's called being anergic.
Got it. Let's look at her social history. She was born in Ivory Coast, West Africa, but has lived in the U.S. for over 20 years, hadn't traveled recently, lived with her children, didn't smoke, drink, or use illicit drugs. Divorced, reported only one lifetime male sexual partner. Her ex-husband and one child reportedly tested negative for HIV.
Her country of origin, Ivory Coast. That's very important information, especially with the confusing HIV history.
Why Ivory Coast specifically?
Certain infectious diseases, including specific variants or types of HIV, are more prevalent in certain regions, particularly West Africa. The social history, lack of recent travel, or high-risk behaviors noted. But the key here might be that remote history and origin. The negative tests in her ex and child are somewhat reassuring for recent transmission, but don't clarify her own past status or exposure.
Back to her evaluation at the second hospital. Vitals, similar, blood pressure still high, 165/99. Her BMI was 22.5, healthy range, which maybe makes the 33-pound weight loss even more striking. Physical exam findings largely consistent with the first hospital. Alert, oriented, slow but clear speech, intact eye movements.
But some additional subtle findings noted on this more detailed exam. Mild right esotropia, that's one eye turning inward slightly. And interestingly, no nystagmus noted on this exam, unlike the first hospital. Also, mild deviation of her tongue to the left.
Subtle dysmetria still present, worse on the right, confirming the coordination issue. She had the unsteady ataxic gait and impaired balance. Psychomotor slowing again noted. Rosenberg sign absent. Strength, Sensation, reflex is normal.
Okay, the mild esotropia, tongue deviation, subtle signs of cranial nerve dysfunction, could suggest the underlying problem, like a lesion or swelling, might be affecting the brainstem, where many cranial nerves originate. Brainstem's closely connected to the cerebellum, so it fits the overall picture. The absence of nystagmus now compared to the first exam is curious, maybe transient. Maybe the steroids she got before transfer helped. The persistent dysmetria and ataxia with normal strength and sensation still strongly point to the cerebellum and its pathways. Absence of Rosenberg sign testing balance with eyes closed while still being unsteady with eyes open sometimes suggests cerebellar ataxia rather than sensory ataxia.
Two other findings on physical exam really stand out and add weight to the possibility of an underlying systemic issue, maybe related to her immune system. She had alopecia, or hair loss, and oral thrush.
Ah, oral thrush, candidiasis in the mouth. Classic opportunistic infection.
Meaning?
In a healthy adult, you usually only see it after antibiotics or inhaled steroids. In someone not on those, oral thrush is a strong indicator of underlying immunosuppression, particularly affecting T-cell immunity, the type heavily impacted by HIV. Alopecia could be many things, but in this context of systemic symptoms, potential immune deficiency could be another sign of widespread illness or poor nutrition from chronic disease. These two findings, especially the oral thrush, significantly increase suspicion for a compromised immune system. Makes that confusing HIV history suddenly feel much more relevant.
She was admitted for further evaluation. This is where we get the critical lab results. Her routine labs, kidney, liver, thyroid, electrolytes, B12, blood sugar, mostly normal. Good news for those organs.
Okay, brace yourself. Here's where the HIV mystery starts to unravel, but also gets even more complex initially. The standard HIV screening test looks for antibodies to HIV-1 and HIV-2, and HIV-1 P24 antigen came back reactive.
Reactive.
Yeah.
So, positive. That aligns with the idea the initial diagnosis 13 years ago might have been right, and maybe the second test was wrong. But at UT, the plasma HIV-1 RNA level, the viral load test, specifically measuring HIV-1 virus in the blood, was not detected.
Yeah, this is the really confusing piece if you're only thinking typical HIV-1. In someone with symptoms like oral thrush, severe weight loss, likely opportunistic brain lesions, all signs of advanced disease, you'd expect a very high viral load if it were untreated HIV-1. An undetectable HIV-1 viral load here is highly unusual, a major disconnect needing explanation. And then the CD4 plus T-cell count, key marker of immune health in HIV. Hers was 39 per microliter.
39. Normal is several hundred. That's profoundly low.
It is. CD4 count below 200 defines AIDS. A count of 39 indicates severe immunosuppression, puts her at very high risk for a wide array of opportunistic infections, certain cancers, including things causing brain lesions and oral thrush. So we have clear evidence of devastating immune damage, CD4 equals 39, a positive test suggesting HIV, but no detectable HIV-1 virus. This pattern just doesn't fit standard advanced HIV-1.
Looking at her other labs in Table 1, total white blood cell count was elevated, over 12,000, mostly neutrophils. Often suggests the body's fighting infection or inflammation, maybe the thrush or brain lesions. But her lymphocyte count, including CD4 cells, was quite low at 695, which fits with the critically low CD4 number. Some immature white cells, too, maybe bone marrow stress.
And her urine tests also showed infection signs. Protein, leukocyte esterase, lots of white cells, bacteria, suggests a urinary tract infection is also present. Another opportunistic infection she's likely vulnerable to.
Finally, let's look at the other imaging done CT scan of the chest, abdomen, and pelvis, with contrast. Chest CT showed a mildly enlarged left thyroid gland with nodules and scattered pulmonary nodules less than 4 millimeter.
Thyroid findings probably incidental, maybe goiter. Small lung nodules, common.
Yeah.
Can be old infections, inflammation, sometimes metastases, though these were tiny, non-specific.
The abdomen and pelvis CT showed a small, benign liver lesion, but importantly, it revealed diffuse colico-osseous lesions in the thoracolumbar spine and pelvis.
Lytic osseous lesions, areas where bone is being destroyed. Diffuse means spread out across multiple bones, spine, pelvis. That's highly concerning for a widespread process affecting bone.
Like what?
Top contenders for diffuse olytic bone lesions are metastatic cancer, multiple myeloma, a bone marrow cancer, or disseminated infections spread to bones, like TB or certain fungal infections. This adds another major piece to the puzzle, a systemic process outside the brain and mouth affecting our skeleton. This is where the differential has to expand even further to connect brain findings with findings elsewhere.
Okay, let's pause here. Put together what we know before confirmatory tests. Woman with progressive neurosymptoms, severe weight loss. Significant brain lesions on MRI multiple, enhancing one necrotic. Oral thrush. Severe immune suppression, CD439. positive HIV screen but undetectable HIV-1 viral load, plus potential disseminated disease, bones, lungs, and that confusing HIV history, the most pressing puzzle, figuring out her true HIV status, given the conflicting labs and history.
Absolutely. This is where the deep diagnostic thinking kicks in. As the source material lays out in Table 2, we have to interpret this unusual pattern. Positive HIV screen, undetectable HIV-1 viral load, profoundly low CD4 count. What causes this specific combination? Source runs through possibilities. 1. The positive screen is just a false positive. Modern tests are accurate, but false positives happen. Rarely.
But if it's a false positive, how on earth do you explain the CD4 count of 39? That's proof of severe immune deficiency.
Exactly. Major flaw in the false positive idea for this patient. You'd have to argue she has both a false positive HIV test and a very rare condition called idiopathic CD4 plus T-cell lymphopenia low CD4 for no known reason. Source notes this combo is possible, but highly unusual, unlikely to explain everything. Another idea. She's HIV-1 positive, but an elite controller. Very rare individuals whose immune systems naturally suppress the virus to undetectable levels without meds.
Could an elite controller have a CD4 of 39 and be symptomatic like this, with thrush and brain lesions?
Possible, but less typical. Elite controllers usually maintain healthier CD4 counts longer, though slow progression can occur. Given the severity of her immunosuppression, less likely than other explanations. A third possibility, and here's where her origin becomes crucial again, is she's infected with a rare subtype or group of HIV-1 that the standard HIV-1 viral load test doesn't pick up. Certain rare strains circulate in West and Central Africa. The screening test might be positive, detects broad antibodies, but the HIV-1 specific viral load test would be negative, even though virus is present and destroying her immune system.
That's a fascinating scenario, directly tying her origin to the strange test results.
It does. Other less likely explanations. Maybe secretly taking RT, suppressing the viral load, surreptitious RT, or lab error like sample mix-up, though again, wouldn't explain the consistent low CD4. Finally, and as strongly suggested by the source and her history, the possibility of infection with HIV-2, a separate virus from HIV-1, though related, also prevalent in West Africa, including Ivory Coast. The critical point, highlighted by the source. Standard HIV-1 viral load tests do not detect HIV-2 RNA.
So this is where it starts to make sense. If she has HIV-2, the screening test would likely be positive, detects antibodies to both. But the HIV-1 viral load test would be negative because it's looking for the wrong virus. And HIV-2 also attacks CD4 cells, leading to immune suppression.
Exactly. This pattern, positive HIV screen, undetectable HIV-1 viral load, low CD4 count, especially in someone from West Africa, strongly points to HIV-2 infection. And that confusing history from 13 years ago, very plausible she was diagnosed with HIV-2 back then, maybe put on RT effective against HIV-2. Then later testing that showed she didn't have HIV might have only looked for HIV-1 or misinterpreted results, leading to bad advice to stop treatment. Years later, untreated HIV-2 immune system progressively failed, leading to the severe immunosuppression we see now. So with the strong suspicion of HIV-2-associated AIDS, given CD4 of 39, likely explanation for tests, we now revisit the differential for her neurological findings and other systemic issues, but in this context of severe immunosuppression.
Right, so what's on the list for ring-enhancing brain lesions with necrosis and edema in someone with advanced HIV/AIDS, likely HIV-2?
Source lists the main culprits for contrast-enhancing mass lesions in severely immunocompromised AIDS patients. Toxoplasma gondii encephalitis, cerebral toxoplasmosis, tuberculoma from CNS TB, primary CNS lymphoma, cryptococoma from cryptococcus, bacterial or fungal brain abscess, neurocysticercosis, syphilitic gumma. Based on her specific presentation, especially imaging features, multiple enhancing lesions, one necrotic, mass effect, and profound immunosuppression. The source narrows the leading possibilities among HIV-related causes, primarily to Toxoplasma gondii encephalitis, tuberculoma, and primary CNS lymphoma. These are the most common causes of this type of lesion in this population.
Okay, why are those three top contenders? And what features make toxoplasmosis the leading suspicion, as mentioned?
Source points to several factors favoring Toxoplasma gondii encephalitis. First, historically, it's the most common cause of brain mass lesions in AIDS patients not on prophylaxis. Our patient, having stopped ART years ago, wasn't getting the standard preventative med, trimethoprim sulfamethoxazole. Second, her origin, Ivory Coast, has high exposure rates to Toxoplasma gondii, 60-70% seroprevalence. Means she was likely exposed, carries the latent parasite, which can reactivate when immunity drops. Third, her CD4 count is 39. Well below the usual threshold of 100 where toxo reactivation occurs. She's high risk. And finally, the imaging features are classic. Ring-enhancing lesions, essential necrosis, especially multiple lesions, mass effect. Highly suggestive of toxoplasmosis on MRI. Although lesions are commonest in basal ganglia, they certainly happen in the cerebellum.
So severe immunosuppression, compatible imaging, no prophylaxis exposure history makes toxo a very strong contender. But what about TB and lymphoma? Why still significant possibilities, especially with the other findings?
Exactly. While toxo's leading, can't ignore tuberculoma or primary CNS lymphoma. Tuberculomas can also be multiple, ring-enhancing, sometimes necrotic, cause mass effect, and disseminated TB. Major cause of weight loss can cause olytic bone lesions, pulmonary nodules findings she also had on her body, CT. So TB remains a very strong possibility that could potentially explain everything. Systemic symptoms, bone lesions, lung nodules, brain lesions. Primary CNS lymphoma also commonly presents as ring-enhancing brain masses in severely immunocompromised patients. Can be associated with systemic symptoms like weight loss, often solitary, but can be multiple. So TB and lymphoma are crucial alternatives, especially considering findings outside the brain.
With these possibilities, especially the strong suspicion for HIV-2 and toxo, what diagnostic tests were done to confirm things?
Source describes the key tests. To clarify the confusing HIV results and confirm suspected HIV-2, her reactive HIV screen was sent for a follow-up HIV-1 and HIV-2 antibody differentiation assay at a specialized reference lab. The result: the differentiation assay showed HIV-2 specific bands, definitive confirmation she's infected with HIV-2. Subsequent testing also detected plasma HIV-2 RNA level of 486 copies ml, confirming active viral replication, though HIV-2 loads tend to be lower than HIV-1.
So the HIV mystery is solved. She has HIV-2 infection, explains the positive screen with negative HIV-1 viral load. Her severe immune deficiency is due to advanced, untreated HIV-2. Strongly supports the idea her previous diagnosis might have been correct.
Yes, it all fits now. And what about confirming the cause of the brain lesions? Serologic testing for Toxoplasma gondii was done.
Results were positive for IgG antibodies and negative for IgM.
Positive Toxoplasma IgG means she's been exposed sometime in life. Expected, given her origin. Negative IgM suggests not a recent primary infection. In the setting of severe immune suppression, CD439, and compatible symptom imaging, ring-enhancing brain lesions, a positive IgG is considered strong evidence of reactivation of latent toxoplasmosis. While definitive proof needs a brain biopsy showing the parasite, in practice this combo severe immunosuppression compatible imaging, positive toxo IgG is usually enough to make a clinical diagnosis of cerebral toxoplasmosis and start treatment. Other possibilities like TB, lymphoma typically need biopsy, but given high likelihood of toxo, empirical treatment for toxo is often the first step.
So, testing confirmed HIV-2 infection and strongly supported cerebral toxoplasmosis as the cause of her acute neurological issues and brain lesions. What does the source tell us about managing these?
Let's start with managing the underlying HIV-2. Source refers to guidelines. Notes that while HIV-2 generally progresses slower than HIV-1, it absolutely still causes immune deficiency, AIDS, death if untreated. Fewer big trials specifically for HIV-2 treatment compared to HIV-1, but based on available data, recommendation is start ART at or soon after diagnosis, just like HIV-1. Prevent progression, transmission. Given her advanced disease, opportunistic infection, starting ART is urgent.
Does the same ART work for HIV-2 as HIV-1?
Crucial point, highlighted in Table 3 of the source. Explains why using a standard HIV-1 regimen without thinking could be disastrous. HIV-2 is intrinsically resistant to two major drug classes: non-nucleoside reverse transcriptase inhibitors, NNRTIs like efavirenz, nevirapine, and the fusion inhibitor enfuvirtide. They simply do not work against HIV-2.
So you can't just pick a common HIV-1 combo pill. Regimen has to be specifically active against HIV-2.
Exactly. For initial treatment, guidelines suggest a regimen based on an integrase strand transfer inhibitor in STI, plus two nucleoside reverse transcriptase inhibitors, NRTIs, similar to preferred HIV-1 regimens, but the specific NRTIs and NSTIs chosen must have proven activity against HIV-2. Alternative, a boosted protease inhibitor, PI, plus two NRTIs, again choosing PIs known effective against HIV-2, as some HIV-1 PIs have reduced activity.
What about monitoring treatment success? Same as HIV-1.
Mostly, but with a key difference. Monitor HIV-2 RNA viral load, CD4 count, clinical status, want viral load undetectable, CD4 count up. However, source notes, unlike HIV-1, where CD4 monitoring can sometimes stop if viral load is durably suppressed and CD4 high, for HIV-2, periodic CD4 monitoring should continue even if viral load is persistently suppressed.
Why is that?
Because in some HIV-2 patients, reports of immune decline and clinical progression despite undetectable viral loads. Unique nuance of HIV-2 management.
And given her history of potential prior treatment, is drug resistance testing important?
Ideally, yes. Prior exposure means potential resistance risk. But a source points out a practical challenge. No FDA-approved HIV-2 genotypic or phenotypic resistance assays for routine clinical use in the U.S. currently. So, testing options limited, usually for research or suspected treatment failure.
Source also mentioned screening for co-infections common in West Africa, like Hep B, strongyloidiasis, HDLV.
Right. Comprehensive care involves looking for other common infections, especially from patients' origin region, can impact health, treatment. Rescreening for TD also important, maybe with IgRA blood tests, as her low CD4 likely made prior men2 unreliable.
And with CD4 of 39, very high risk for opportunistic infections.
Yeah.
Needs prophylaxis.
Absolutely. CD4 under 200, standard guidelines recommend prophylaxis against pneumocystis jirovecii pneumonia, PCP, usually trimethoprim sulfamethoxazole, Bactrim. CD4 under 100 and positive toxo IgG also needs primary prophylaxis against cerebral toxo, also usually Bactrim. However, once treated for acute toxo, she'll need secondary prophylaxis to prevent recurrence. Now, let's focus specifically on managing the cerebral toxoplasmosis, cause of her acute neurological crisis.
Source indicates treatment for cerebral toxo should involve specific antiparasitic therapy, along with prompt initiation of RT for the underlying HIV.
Standard initial treatment regimen for cerebral toxo is combination of sulfadiazine and pyrimethamine. Leucovorin, folinic acid, also given alongside pyrimethamine to prevent its bone marrow toxicity, which can cause low blood count.
But the source notes a real-world challenge. Pyrimethamine has become extremely expensive, hard to get in the U.S. recently.
That's a harsh reality impacting care. Source highlights if pyrimethamine unavailable or cost prohibitive, recommended alternative is high-dose trimethoprim sulfamethoxazole, which works against toxo. Other alternatives like clindamycin plus pyrimethamine or atovaquone exist, but generally considered less effective than standard regimen.
What about timing of starting the HIV-RT relative to treating the toxo? Risk of that immune reconstitution inflammatory syndrome, IRIS, if you start ART too soon?
Critical question. IRIS happens when recovering immune system, boosted by ART, overreacts to infection, sometimes worsening symptoms. However, a large randomized trial mentioned in source looked at ART timing in patients with various opportunistic infections, showed starting ART early within 14 days of starting OI treatment led to better overall outcomes, less progression to AIDS or death compared to waiting longer. While that trial had few toxo patients, overall evidence suggests in most severe OIs, benefit of starting ART early to rebuild immunity outweighs IRIS risk. So source concludes reasonable to apply these findings here. Recommend starting HIV-2 active ART fairly quickly, typically within days to a week of starting toxo treatment once patient's stable, tolerating antiparasitic meds.
Let's look at how her case actually progressed after starting treatment. Upon discharge, she'd already seen some improvement, moderate reduction in weakness, confusion, gait instability. Headache resolved, maybe due to BP control or reduced brain swelling from steroids and starting lesion treatment. Remained without fever.
Initial improvement is a positive sign, suggests treatments were having a beneficial effect.
Her discharge meds reflected the plan. For HIV-2, tenofovir alafenamide, amtristabine, dolutegravir, and NSTI plus 2 NRTIs, recommended HIV-2 regimen. For cerebral toxo, pyrimethamine, sulfadiazine, leucovorin, standard triple therapy.
Regimen aligns perfectly with recommendations, assuming these drugs have HIV-2 activity and standard toxomeds were available.
However, at 1-week follow-up, significant complication. Blood creatinine, marker of kidney function, rose sharply to 3.5 milli-GDL, way above normal. Urine test showed high percentage of eosinophils, about 70%.
Creatinine jump like that indicates acute kidney injury. Eosinophils, type of white cell often linked to allergic hypersensitivity reactions, finding them high in urine with acute kidney dysfunction. Strong signal of drug-induced kidney problem, specifically acute interstitial nephritis. Sulfadiazine, one of her toxomeds, is a known potential cause.
And indeed, she was diagnosed with sulfadiazine-induced acute interstitial nephritis.
Highlights importance of close monitoring, especially with multiple meds, complex patients. Drug side effects are a common challenge.
As a result, sulfadiazine stopped immediately. Toxo treatment changed to pyrimethamine, clindamycin, leucovorin. Clindamycin is another alternative effective against toxo, also prescribed atovaquone for PCP prophylaxis.
Switching to clindamycin is standard approach when serious reaction to sulfatazine, and since she reacted to a sulfa drug, likely couldn't take trimethoprim sulfamethoxazole preferred PCP prophylaxis, so atovaquone is suitable alternative.
Follow-up continued. At 3-month checkup, renal function improved significantly after stopping sulfatazine. Critically, HIV-2 viral load now undetectable. At 6 months, repeat head MRI showed excellent news. Marked decrease in size of large ring-enhancing lesion in right cerebellum, complete resolution of smaller lesion in left frontal lobe.
Fantastic progress. Confirms treatment strategy worked. Kidney function recovery shows nephritis resolved. Undetectable HIV-2 viral load is primary RT goal, strong indicator virus controlled. Dramatic improvement in brain lesions shows toxo treatment, initially sulfa, then clinda. Effective in clearing parasite, resolving inflammation, mass effect.
1 year after starting RT, her CD4 plus T cell count increased to 203 per microliter.
Major milestone in immune recovery. CD4 above 200 means much lower risk for many OIs, including PCP, toxo, though secondary toxo prophylaxis might continue ensuring durable suppression. Immune system rebuilding, key to long-term health with HIV. As source noted, CD4 recovery sometimes slower in HIV-2, so reaching 203 in a year is good progress.
And finally, that crucial, confusing detail from her past clarified. Discussion with previous provider confirmed she had been counseled to stop RT about 8 years earlier. Why? Because that provider incorrectly interpreted her initial positive HIV screen and subsequent negative HIV-1 viral load as a false positive result.
Wow. Confirms our hypothesis about the cause of her immune crash years later. Seems a clinician, likely unfamiliar with HIV-2 nuances or misinterpreting standard HIV testing algorithm, saw a positive screen, negative HIV-1 load, concluded false positive, advised stopping treatment. Underscores critical importance of understanding diagnostic complexities, especially for less common conditions like HIV-2. That single misinterpretation 8 years prior directly led to life-threatening AIDS-defining conditions, severe neurodisease. So, putting all the pieces together from this incredible case, initial symptoms, confusing but revealing imaging pattern, brain tissue uncoverings, severe immune suppression, thrush, body findings, solidic bone lesions, specific HIV test pattern, history origin, confirmation via specialized testing, response to targeted treatment, the final diagnosis established.
And after all that detective work, the final diagnosis in this complex case is human immunodeficiency virus type 2 infection leading to acquired immunodeficiency syndrome and cerebral toxoplasmosis is the primary opportunistic infection causing her neurological symptoms.
An absolutely fascinating case. Touches on diagnostic pitfalls, importance of geographic history, distinctions between HIV types, complexities of managing severe immune deficiency, and opportunistic complications. The oolitic bone lesions, pulmonary nodules. Not definitively explained in this source material, but in real world would likely prompt further investigation. Rule out disseminated TB, other widespread infections, malignancies possible in advanced AIDS, definitely on our differential earlier. But the most acute life-threatening issues were clearly HIV-2 and cerebral toxoplasmosis, successfully diagnosed and managed.
What a deep dive. That case really pulls together so many different aspects of medicine, neurology, infectious disease, immunology, diagnostics, the critical role of patient history. Highlights how something seemingly simple like a headache or trouble walking can stem from an incredibly complex underlying process.
It certainly does. Powerfully demonstrates importance of connecting all the dots, listening carefully to the full story, considering background like origin, not being satisfied with unexpected labs, but using them as clues, having access to specialized knowledge and testing to unravel the true illness.
And that revelation about the previous diagnostic error, that's both disheartening and a potent reminder. Shows how crucial accurate test interpretation is, how devastating consequences of misdiagnosis can be, even years later. Speaks to need for continuous learning as diseases and diagnostics evolve.
Absolutely. Stark illustration of why getting diagnosis right from the start is paramount, why stopping treatment for a chronic, potentially fatal condition always needs rigorous confirmation.
Case also gave a glimpse into nuances of treating HIV-2 specifically, challenges with drug availability, need for careful monitoring for complications like drug-induced kidney injury.
Indeed, managing these complex patients requires not just correct diagnosis, but navigating treatment practicalities, vigilantly monitoring for adverse events.
So what can we take away from this as listeners? Perhaps appreciation for incredible complexity of the body, the detective work in medicine. Also a reminder that asking questions about your own health info, especially when things seem confusing, is always a good idea.
And it raises an important question for the healthcare system. How can we ensure complex conditions or less common types like HIV-2 are universally recognized, accurately diagnosed, regardless of where care is sought, to prevent such critical errors and ensure everyone gets the correct life-saving treatment? Something this case compels us to think about.
A challenging and vital thought to leave you with. Thanks for joining us on this deep dive into a truly fascinating medical puzzle. We hope you found it as insightful as we did.